That was highly unnecessary, and I am filled with anxiety now, but it's a good start to what's going to be a fun live stream. My name's Peter Birch, and I'm going to bring on Dr. James Somauroo now. James, how you doing, buddy?
I'm all right, thank you. Yeah, my anxiety's peaked now that you've given that just outrageous introduction.
That's unnecessary, right? It's like 8 o'clock at night here in Sydney, so I thought, why not, G up a bit and see what we can do.
Nice.
But,
nice.
Yeah. So for those that might be just stumbling across this, you might be watching on LinkedIn, you might be watching on Facebook or on YouTube, and you could be watching live right now. So if you are watching live right now, put a comment through whatever platform you are watching on, and we can see those and we can chat about those things, because for the next hour or so we'll be just doing a bit of a Q&A and really chatting about health tech across Australia and the UK and anything else, really, whatever comes up. It's we did one of these back in, when was it? February, I think.
Yeah, I'd say February-ish.
Yeah, and it was good. It was good engagement. It was at a different time, so I'm curious to see what kind of engagement we get. Now it's a bit later in the day here in Sydney, and you're not just waking up there in the UK there, James. So that's fair enough for you. But it's good. We've got some people just starting to show in now on LinkedIn, which is great. Nathan, part of the THT Plus community, and there'll be others joining on too. So. How's things been with you, James? You've been busy since we last spoke.
I've been busy. Podcast stuff obviously going well. Pumping out 2 episodes a week still. Still seeing some growth on that stuff. It's crazy. I think just the health tech community in general globally is just getting more and more wide. It's definitely getting more and more deep. There's loads of people in it, and I think it's an increasing sector. There's more and more money flowing in, private equity, VC. That means there's more startups. That means there's more people that work in startups. That means there's just more people interested, right? And so I think the podcast, as you'll know, with yours, I think that popularity is just going to keep kind of trickling through. And I think there's just going to be this sort of slow, steady growth on that stuff as our sector kind of increases in size, which is great. I mean, it's awesome to be part of it. So the podcast's going well. I've launched SomX, which is my communications and innovation agency for health tech startups. Again, part of the sector now, right? There's all these services companies popping up specific to health tech, because as we know, health tech is a really complex beast, and it needs really kind of sector specific expertise. And with me kind of running accelerators previously, it was one of those things that the biggest problem that I ended up solving was communication, whether that was picking out their exact audiences that they needed to speak to, telling them exactly what they needed to say to a CIO of an NHS trust versus a US employer versus an Australian insurer. There's different value propositions that are super specific to health tech. Even in the same building, you have to communicate 5 or 6 or 7 different value propositions, right? So anyway, ended up doing that, ended up helping all these companies with that stuff. That's where SomX popped up, and launched it properly, although it's been around for about a year. Launched it properly on Tuesday.
Fantastic.
So that's where we're at.
Good on you. Yeah, well, we've on the Talking Health Tech side of things, we've been busy as well, because we're doing 2 episodes a week on the public feed now, and plus an extra bonus episode for members as well. But I think we released episode 150 something this week. So I think I saw you just passed 200. So
we got past 200.
yeah. Keeping busy.
With no fanfare about it though. Like literally, it was just one of those things. Like 200, 300 will be coming around pretty soon. So I don't want to set a standard of what I have to do for every 100.
But look, so for the next hour or so, there was some chat that happened before the session, and people were suggesting some things for us to talk about. I'm also very open to being guided by the chat here as well. Something that I thought we could do as well, James, while people suggest some topics and some things to talk about. I didn't even suggest this to you. We hardly prep for this at all. But what I'm going to do, I'm going to share my screen. I'm going to pull up the good old wheel. And so the wheel, we use this in the community forum for basically deciding how to do things, right? And so I'm going to put in a few topics for us to talk about, and feel free to suggest some as well. And we'll use any that the community suggests now too. Blockchain, everyone likes to suggest blockchain, so we can put that on there. We can talk about, what else is there? It's like podcasting. That's always a popular one. Lockdowns, because I'm in Sydney and you're in the UK. Good one on gamification would be a good one to talk about, because I'm keen to get your thoughts on something. But if you're watching on YouTube or on Facebook or on LinkedIn, you can suggest any topics for us to talk about, and we can spin the wheel and see what's on. But is there any hot topics that's on your mind at the moment, James, that you want to chuck on the wheel?
You could throw in all the usuals, the AI, machine learnings. You could talk digital therapeutics. You could go down those routes. What else? Decentralization. Let's put that on.
All right. Let's go with that. And then we'll go. We got Ben suggested UX as well. So we've got that on here. And we got another one for UX. So we got the few votes for UX going on here. We'll give it another 10 seconds. The wheel has basically decided everything in my life for the past 6 months, James.
I'll tell you what, this is ideal. I've just taken a note of the URL here, because this is a fabulous piece of kit.
You got an important decision to make. Put it on the wheel.
Put it on the wheel.
Just, let the wheel decide. So that looks like we've got the votes for now, and people are anxiously waiting. I'm going to click it and see how we go. So we'll give it a couple of seconds. It's a big spin too.
That's a big spin.
I think it's going to land on digital therapeutics. Oh, and there's still some votes that came in as well, which we can chuck in for the next one. So digital therapeutics.
Yeah, so digital therapeutics. Yeah, so we've been working with a couple of clients at Somex actually that are digital therapeutics companies, and I think it's super interesting for me seeing, I suppose, the change in the value that they're starting to bring. I think historically, the likes of Sleepio, the big one initially, and a few others after that, sort of went down the let's go B2C or B2B via employers and just get things in the hands of people to use. And it was very much a kind of a relationship between the app and the person. And that was the relationship seemingly. You can manage your condition better using this app, and that's yours, and that's everything there. I think what I've learned of late is the healthcare systems are now coming into that as a third party, and there's additional value being brought and additional value being given in that third part of the relationship, or second part of the relationship. So, for example, one of ours, Ampersand Health, that we've been helping. So yes, they have an app for inflammatory conditions, whether that's inflammatory bowel or arthritis, this, that, and the other. But rather than it being just that relationship between the person and the app, which helps them manage their condition, which it does, education, and all that stuff, what there is a portal that allows you to self-report your symptoms to a hospital. That hospital and those clinicians can then triage based on how you're doing. So it's like remote monitoring, basically, but it's just self-reporting.
I was going to say, like the digital therapy, like what makes it, for those that are not familiar with digital therapeutics and just trying to work out then what you're explaining there, because it sounds like remote monitoring, like you say, like what makes it digital therapeutics?
I suppose the fact that because they are self-reporting, in this case, the clinicians are then able to communicate the other way and to provide advice and to call them in when they need to be called in. I suppose the educational element as well makes it a therapeutic. The fact that you will change the way that you manage your condition based on the education you're receiving from the app. And so, so it's that. But I think the interesting thing for me has been, so outpatient departments are now changing who they bring in, because they can tell who actually needs to come in. So no longer are people kind of in this situation in a few hospitals that this is in. No longer is it this kind of, and if there are any clinicians listening, you sat in clinic and then you call the next patient in. Oh, you're fine. Cool. You can go home. 1 minute appointment. What's the point? Patient's taken half a day out. They've paid for parking. They've taken a day off work. All that just nonsense and hassle. But now outpatient departments are like, these are the 5 people we need to see, and we're actually going to double the appointment times because these people are unwell, and therefore the whole population that they're looking after helps. So I guess I'm seeing this change. I'm seeing a change of healthcare providers being brought into this conversation with digital therapeutics and actually the system, and it's developing just a new way of doing outpatients. Words being bandied about asynchronous communication. That's, one thing about this reporting, outpatient reform. It's all these different things. So things are moving on slightly.
Asynchronous communication is very, very in 2021, isn't it? A lot of people talking about async at the moment. It's but one thing that Robert Samuel brought up is about regulation and digital therapeutics in the UK. Any insights in terms of how that's progressing on that side?
So depends what the app does, whether it's giving advice, whether it's diagnosing, whether it's treating. But it's treated like any other device from regulatory perspectives, in that it will have to be regulated as a class 1, class 2, CE marked medical device here in the UK. And so it's treated as such. So that's the way that it's dealt with from a regulatory perspective. And I think because of that, I think the people that build digital therapeutics are very careful about exactly what it is, exactly what the intended use is, and being very strict on that to make sure that they only have to be a class 1, or indeed they are confident that it is a class 2 and they go down that route. So
interesting. So we can see here there's a few people have joined in the chat, mostly on LinkedIn, which is great. Good platform to do it. Hey Anna, thanks for checking it out. A lot of Aussies dialing in, probably in their pajamas. So that's
chilly Sydney. That's interesting. It is absolutely roasting here in the UK.
Yeah.
31 degrees.
I was going to say, is it like 27 degrees? Like that's roasting.
I was going to say, what's chilly for Sydney though?
That's, Robert, I was actually thinking that around the software as a medical device and the TGA. That's very similar themes what we were talking about before in relation to digital therapeutics and the challenges around putting a box around algorithms and everything and regulating them in something that's always agile, to then call it a medical device, which is usually quite static. Is that's a long ongoing thing. I'm gonna spin the wheel again, and we're gonna bring up a new topic for those that are just joining. It's Peter Birch and Dr. James Somauroo, budding health tech podcast. As I say that, like we're aspiring, but we've got about 300 and something episodes amongst us, and 11 degrees. It is chilly here.
It's actually chilly. Yeah, fair enough.
Yeah, okay. So, but we're talking about different things. Feel free to suggest something quickly for the wheel before we spin it again. We've taken digital therapeutics off. We've added change on. I'm going to spin it now, and feel free to suggest something while you're spinning away. I wonder if I click it harder, whether it'll spin faster. It's going to be the typical topics, but they're front of mind. Artificial intelligence and machine learning. Okay.
I don't have much to add on this. I don't know why I said it, to be honest. It's all still going on. I think the only thing that I would say in the UK is that there's a lot of central funding going to this now, and it's funding at more of the top end of startups. It's the Series B, Series C companies that are now actually getting significant funding from like NHSX. They've got a big AI award, and so there's actual patients being impacted in a very positive way, starting to be at scale. It's becoming one of those things that even as I introduce this, it's like, oh, AI machine learning again. We've been talking about it for so long. It's kind of it's happening. Like it's happening. It's being used, and it's sort of becoming a bit boring almost from our side of the table, because it's being used and it's working, and all these things that people were concerned about, like
exactly.
Not a lot of them are coming to the fore, but
you mentioned I noticed there's a few Australians that are on, and just now it's a big competition on who's the coldest right now. I think Armidale's winning at the moment. It feels like it's under. Brisbane's a chilly 31 degrees, so good on Brisbane. That's But the point around NHSX, we've heard a little bit about it here in Australia, and I'm a little bit jealous of it being in existence. But for those that don't know, did you want to give that a bit of a high level?
Yeah, sure. So again, I'm not a complete expert on this, but I have worked in that world, and I've got a pretty good understanding of this. I actually spoke to Indra Joshi on my podcast, who is the director of AI at NHSX, a previous clinician herself. But when the NHS is a complex beast, and there's lots of facets to it. NHS England is a big commissioning organisation, and so I suppose in order to get more information and enable it to make decisions and influence policy and decision making in a technological world. It needed, I think, a specific group of people that understood that in order to make policy that drove that area forwards in the right way. And so they set up NHSX, and forgive me if anyone's from NHSX that I've just butchered the explanation of your organization, but they have done an incredibly good job from my vantage point in a few different areas, one of which is, I suppose, putting digital health tech on the map somewhat to people for whom it was not on the map previously. I think having a body like NHSX even in existence, it's known globally that clearly it has done a lot for kind of awareness. I think the other thing that they've done really well is they've done, well, they did here's an example of what they did, right? They did like a 10 or 12 point guide for hospitals, which was, here are the 12 questions to ask an AI provider if they come to you selling their kit. Right. These are 12 questions to ask them. And they padded that out into a bigger document and stuff. That in itself, I believe, is incredibly useful because, again, there's people that, fair enough, don't have an interest in this stuff. They're running a hospital. Yeah. They might be interested, but similarly, they might not. They just want the answer. And I think things like that allow for that conversation to even exist, rather than it being like, oh, I don't really understand it. Like, no, we're going to stick to brick and mortar. We're going to do this stuff. We're going to do that stuff. So they've done so much, I think, for fostering the right amount of policy and governance. It hasn't felt overwhelming. And at the same time, it hasn't been so high level and so light touch. I feel like it's genuinely made a difference. And that's me being very honest. Like, I really do. It's done a good job of bringing everyone on that tech side and on that kind of, I suppose, procurement-y management side and putting it in the middle, which has been quite nice. Yeah.
I mean, here in Australia, we've got, the Australian Digital Health Agency, I guess. We do have the Australian Digital Health Agency, probably different remits and not pulling together so much of those actionable real world things that you're talking about and putting it in context for clinician, at least from my own perspective, probably. But there is a lot going on behind the scenes, which at least these days it's moving more towards things other than just our My Health record, the personally controlled health record thing that we've talked about for a long time. I don't want to go into I don't want to put that on the wheel. That would be a whole nother conversation, and that sparks probably a lot of excitement in the chat for those that are really passionate about it. But I feel like that kind of, like, we do have industry bodies like the Medical Software Industry Association and other ones that kind of do that work. But I think having that at a policy, like at a national level, I see the benefit there.
It's made a huge difference, man. And also, just one more thing on that, they've also been just dishing out money to AI companies, and they're an informed group of people. Like Indra is, a doctor by background, and she's the director of AI, and she makes decisions on, stuff that's hyper relevant. And I think that's a super interesting thing for me, which is when you get the right people to the table. They've got someone called Brummy who's the ethics lead. There's really interesting groups of people that are highly informed about making these decisions, and so it stands to make a lot of impact.
Yeah, cool. I'm gonna get the wheel up. I'm gonna put some other get another topic on the board. Hey to Jody, Ken, all in the chat there. Ross, thanks for sharing. Okay, what did we just do? We did AI ML. Those are checking it out. We're choosing what to talk about. If you've got any topics to talk about that are about health tech, digital health, anything else, could be about, keen to learn more about Somics, actually. Maybe we'll learn something on podcasting. But we're going to go to gamification. Interesting. So I chucked that one on there. And we've got, so recently at what am I doing? Sorry, I got distracted by all of the confetti.
The fireworks.
Yeah, there we go. We'll stop. Can I stop sharing my screen? There we go. On the podcast recently, I think not the episode released today, but the episode on Tuesday, it was a recording of a session on gamification that we held at our winter summit. So we have a live session every 3 months where we have different panelists come on and talk about a particular topic. And I know Nathan, you might still be watching here. I saw him comment earlier. He was moderating that panel, funnily enough. So that's timely. And that was really cool. And so we released that as a podcast episode, which everyone can check out now. I was, some of those things people are already familiar with, but, the use of, not just gamification of, say, results and steps and stuff like that, but I feel like there's so much more in terms of the use of actual games and serious games in healthcare, and I find that a fascinating kind of concept to explore. And we all know about, well, maybe about Pokemon Go and everything. Hey Nathan, he's still here, so that was a great one that he moderated, so thanks for doing that, Nathan. And the use of Fruit Ninja in what is it, the not stroke victims, but the like in terms of cognitive and response times. So
well, I've got a good one, a good example of this actually. Someone that we're working with at the minute called Memory Lane Games.
I listened to your episode. I say that like I'm surprised that I came on your episode. But actually, I tuned in because it was around 200. I'm like, I want to hear what the big fanfare is, and there was no fanfare about episode 200, but it was a really good episode with the one you're about to talk about. Yeah,
with Bruce. So he's found a Memory Lane game. So exactly the same thing. So he's got a gaming background, and so they built a game essentially for him and his mate, his co-founder, for their mums, which was just based on like, here's 4 photos, and essentially there's a question, and you pick one as an answer, and over time they fade away. So it's just like a super easy game. But in people with cognitive decline, dementia, that type of stuff, it is used as something called reminiscence therapy. That is a form of therapy that can basically, bring up old memories and help in that way. And so it turns out that, just as you said, it's not about necessarily gamifying steps and keeping a platform sticky, like in the way that you've described it. This is how Memory Lane Games is being used, and it's that they're doing clinical trials on it. And actually it's, from a relatively simple idea and concept, there's actually a heck of a lot of genuine clinical benefit from it. And okay, you might just say, sounds like common sense, and it's like, well, yeah, but aren't the best ideas that? And we've been doing that stuff for hundreds of years, thousands of years, just telling each other stories and reminiscing about things. And it's like, well, clearly that is linked to a human behavior, and there's a reason that we've evolved maybe to keep doing that, especially with our more elderly friends, and so as reminiscence therapy, that's how Memory Games is actually working. And so they're doing clinical trials now, and it's super interesting.
Amazing. Look, we might, hijack the wheel for a second, because it's a topic that's been suggested, and we can talk about it a little bit if we've got anything to talk on. Someone said, wanted to talk about robotic surgery and the adoption of scalable, in which country would be be able to achieve scale. I don't have, me personally, I don't have any examples of robotic surgery, and we've not done too much robotics on Talking Health Tech actually. But
I've spoken to a guy that identifies by his initials PS, and he's the UK's leading robotic surgeon. So I've actually spoken to this guy, and he works on the Da Vinci machine. So he does, I think it's prostate surgery, urology surgeon. It's the scalability of it. Yeah, good point. I mean, they're hugely expensive machines, and so you're talking about which countries. It's going to be the countries that have the infrastructure and the finances to pay for that stuff. I think there's interesting stuff going on, though. I'd say if you look at companies like Proximy, if you look at things like that, and I think infrastructure is an important thing when it comes to like what's actually the future of robotic surgery, because with the advent of 5G and all that kind of stuff, could you have surgeons in one country that are hyper trained operating using remote robotics in another country? It's going to be possible. Like, we know that. There's that EE advert, isn't there? Like in the UK, for anyone, like there's an EE advert with what's his name? Kevin Bacon.
Yeah, yeah. Actually, I was thinking of something else, but yeah. It's
But anyway,
no,
that's all in reality.
Yeah, there's a few examples that I'm aware of too, of seeing, particularly during lockdown and everything that's happening right now, and being able to like really stretching that concept of providing remote care and doing it for surgery. And internet connectivity is rubbish here. It's probably even rubbish now. I'm probably freezing a lot in this stream, but so probably still a lot of work to do there. But like you say, with 5G and more infrastructure work to be done, that's a lot of possibilities. Cool. So let's bring up We're powering through our list of things to talk about here. If anyone's just joining the chat live, we're spinning the wheel for topics to talk about when it comes to health tech across Australia and New Zealand. Ross is just finishing off a point on robotics. So there's certainly some interesting stuff happening there too. And yeah, the cost is certainly an inhibitive factor. Let's see what lands on the wheel. Some good conversation happening about change as well in there. If you're joining on LinkedIn, on YouTube, on Facebook, we can see your comments on all three. So feel free to comment on any. I'm going to be talking about podcasting, and I'm keen to open this one up because where we, as in talking health tech, we've just started. Well, we're in the midst of doing a podcast series for a not-for-profit that is going to be, so not the Talking Health Tech podcast, but a series which is the target audience is patients that have that have just been diagnosed or they are carers of people who have been diagnosed. And once I've got confirmation we've finalized, I can share more information. But what's really opened up and interested me about the whole process is how powerful podcasting can be as a platform for that particular kind of situation where you've got a cohort of patients who are over a longer period of time, whether it's chronic or whether it's that this is part of their life now, and they need to find their tribe and their people and information and reliable sources to be able to have a podcast with some foundational information where it's conversations with clinicians, like the typical kind of Q&A that might happen in a consult, or questions I haven't even really thought of yet. So we've been able in this podcast to speak with like industry, like global leaders in this particular area, and get their expertise and perspective and ask the silly questions that patients might ask. And there's no issues in terms of patient confidentiality because it's, no patient in particular, but such a cool platform to be able to do it on. So what that has happened is opened up even more not-for-profits and patient, support programs that are exploring podcasting in the healthcare space and have been contacting us now. So, but I originally got this idea because I know you were helping out with the occasional podcast here and there for other companies too.
Yeah, it's a big part of what we do at SomX now. I think it's one of those things that if it's the Gary Vaynerchuk school of content, but everyone should have a podcast, right? Because at the end of the day, you need to be putting out content as a company. You need to be out there explaining to the world what you do. Nobody ever questions writing a blog, so it's baffling to me that people question doing a podcast, which is just the audio form. Yeah. And people might actually listen to that. I doubt many are going to read the blog. So, obvious things around SEO aside, but it's hugely powerful because it only takes one or two of the correct people to listen to your podcast to then give you an opportunity to then push everything forwards. And the other thing is that you can just enjoy it. You can, what we say to people as well, we tend to say, we're going to set this up so that you win when nobody's listening. And so what that means is we get the right guests on, potential customers, potential partners, potential investors, potential, other startups that are interested, or it's just a conversation you might enjoy, so you're not going to waste your hour from that perspective. And also in that hour, you're going to learn to communicate better. You're going to listen to this episode back. You're going to find out what your audible tics are, and you're probably going to correct those. And so it helps you with your presentation skills and everything like that. So it's going to be an hour you enjoy anyway. That's the idea. It should be a guest that is useful in some way to you, your business, or the fact you just wanted to speak to them. And so there's all of those benefits, as well as then obviously all the content that flows out of it. And so, yeah, it's a no-brainer really. It's going to be like a website, I imagine, in the future, which is that I imagine people questioned at the start, why would I have a website?
I don't sell stuff on the internet. Now. I don't need a website because I don't sell things on the internet. But obviously everyone has one now. And I think as well with podcasting too, it's kind of like there's that technical barrier that people kind of go, oh, I don't know how to record something, or I don't want to record something poor, or I don't like the sound of my voice, and I'm, and all of those things. I listened back to the first couple of episodes of Talking HealthTech, and they're absolutely rubbish. The quality of content, like of the guests, was amazing, and so I was really lucky to have those guests come on. But I used to do community radio even before all of this, like back when community radio was a thing, if that ever actually was a thing. But that was pretty average. But when you do that, like you go in of the expectation that no one is listening anyway. I think that's funny that Sylvia just commented. Sylvia was the first episode 1 of Talking HealthTech is with Sylvia Pfeiffer. So thank you, Sylvia, for mentioning that. And it's funny that you mentioned the live streaming thing, because I've started to do more of these live streams kind of for the same reason that I was doing podcasting, which was because I wasn't that good at podcasting. So I thought, well, just keep doing it and then listen back to it and kind of improve on it. One thing that I feel like I was really horrible at was doing these things, like the live video, because you're so used to doing podcasts where it doesn't really matter what you look at and you don't really need to engage with anyone. You can be looking at your notes. But doing a live video thing, that's a new level. And I noticed Sylvia's got a live stream thing coming up soon. So I can see that being a more popular thing coming into. And obviously everyone's been on video for the past 18 months. It's an emerging.
I think what I'd probably add to that though is that when it comes to live streaming or podcast, it's sort of the same as when people go like, oh, put it on YouTube or just leave it as audio. Thinking of it as either or, you don't need to think about it that way. It can be both. It can be all of it. And so, this could quite easily turn up in some format on my podcast, on Pete's podcast, if indeed we wanted it to. And I think, the more places that you can get stuff out, the more platforms. It is amazing to me that the wide range of audience that I can get by literally just putting the same thing out on video, audio, transcribed into written, and then chopped up onto social media, and then with a few graphics and bits and bobs as well. Because literally it is completely different people that listen to the podcast, that read the blog, completely different people that will watch the live stream to absorb it in a carousel on LinkedIn graphically. It's just completely different people. And so I think by missing out, the fact that I don't record my podcast and put it on video, I'm definitely missing an audience, and I definitely need to make that step and just put the things out on YouTube. Then the expert mode would be to live stream it, I imagine, and then you'd get an extra audience there that actually wants to absorb it live. So I think, it's always an opportunity, the different platforms that you put stuff out on, definitely. Yeah.
And I recommend to people also to look outside of healthcare, like for looking at comparing the healthcare space and how we're using these platforms compared to any other industry. It's like here and here, like in terms of the streaming technology that's available, the ability for us to do this across multiple social media platforms relatively easily, when before, doing a live session in healthcare, a lot of organizations still think, well, I'll spin up a WebEx and I'll then make people register for a webinar, which can be good for other reasons. But sometimes if you're just looking for engagement and, building that community or people interested in what you do, this is a good way to do it, the live stream thing. And it's always fun to just experiment and see what you like and give it a crack. I think that's the way, and be comfortable with if no one checks it out. Interesting when you say that, when you think no one's checking it out, or if you do something live like this and if there was no engagement, you know, we've been pretty lucky. There's been quite a few people making comments, which is fantastic and really appreciated. I've done a lot of lives too, where it's like no one has commented whatsoever, and that's like depressing at the time. And you realize that people are still watching, people check it out, it gets recorded, it's not a waste, and it's a great practice experience too. And we've had members join Talking Health Tech who joined because of a live stream that we did. We actually stopped doing live streams a while ago. And only a couple of weeks ago, I learned that there was 2 members that joined because they saw a live stream, like, oh, I really like this idea of the community. So we'll be starting them back up again now. So it's a lot of trial and error, I think.
Good response to feedback.
Yeah, that's right. You know, there's been some good chat that's happening in, good conversations happening in the chat, mostly on LinkedIn. And that's right, Ken, there are a lot of mediums. It's not to say that you need to do everything on everything. Not everyone is Gary V and able to pump out 1,000 bits of content a day because he's got 1,000 people who do that for him. Yeah. You know, start with like interestingly from my side, we used to do a lot on Talking Health Tech through. We wanted to make sure we were doing stuff on Instagram and Twitter and Facebook and LinkedIn and making sure it was, you know, different type of content. And then after a while, realized that LinkedIn's a really good platform for us. It's solid. That's where most of our professional, you know, connections are. So we just focus on that now and make sure we've got a presence on others. So sometimes it's about deciding, you know, choose one, get good at it, and then build on it rather than trying to be everything for everyone. So
yeah,
you know,
that's
and
exactly the same
with,
as me, mate.
Yeah, podcasting, yeah. Cool. I just saw here a question for James around.
Good question, that. So level of activity. So interest from clinicians and piloting. So I used to run the Digital Health London Accelerator. I ran it for 18 months, 2 years, 18 months, something like that. 2 cohorts anyway. And so I saw 61 startups through that program. We got 50 pilots contracts in the NHS, like 300 odd sites with a new innovation in that time. And those numbers all sound great. And, you know, millions saved for the NHS in those things and blah, blah, blah. I think it's a good question, though, about the interest and sort of level engagement from clinicians. It's always going to be a mixed bag. There's always a standard distribution of that kind of stuff. It was interesting in the earlier days of me doing that, because it was sort of cohorts 1 and 2 when I was part of that accelerator. We were often having conversations about digital health for the first time with people. And I think, fortunately, that isn't the case anymore, I don't think. I think you'd struggle to find someone now that hasn't got some experience of health tech or digital health in any sort of clinical capacity, or at least knowledge of it. And so at the very beginning, that was very difficult. And we were actually creating a market there. We were trying to stimulate interest. And so it was pushing a boulder uphill, I think, at that bit. I think since then, things have changed. There are the early adopters and the innovators in the clinical world that jump on the other side of the fence and really try and champion it with people like us that are running the accelerator. And that is incredibly helpful. But, you know, they were and maybe still are a minority. Clinicians are still trying to do their day job for 110% of their day. And so to then try and find even more capacity to help you bring in this digital health solution that's not going to fit in very quickly and very easily, they don't feel is their job on the whole, from my experience. And I think that's okay. I think that's reasonable. I think it is the job of entrepreneurs to understand the environment that they're trying to put a digital health solution into, and to make it easy, and to have someone there to help, and to make sure that there's always a kind of an activation energy. There's always extra effort needing to be put in. Things are going to have to always be slightly less efficient in order to embed something to make it then more efficient. But that sell of going through that process, I believe, is the job of the entrepreneur and the startups. And so, yeah, it's very different levels of interest and engagement. I think for any digital health company, health tech company, it is super important to find clinical champions. Find the clinician that gets excited about what you do and put them on payroll, or give them a role, give them a title, get them out there selling to other clinicians. That is the most effective way of getting over the barrier, which is, that clinical cynicism of getting other clinicians to sell to them. Incredibly important.
I find from my experience, like, spot on in terms of the, finding the inefficient things to do, like find the most unscalable thing to do and do that first and keep doing that until it's, not achievable anymore. I used to choose not to do unscalable things, if that's the right term, because I thought, oh, well, this won't work when we've got thousands of customers. But we didn't have thousands of customers, we had 0 customers. So do whatever's necessary. What I've on reflection to, what I find is that often, if I think about some of the larger contracts that I've been involved with in terms of getting things up and running and executing in health tech, they've come from like one clinician. Like when you could bring it back to like where that big opportunity came from, it's because there's that one advocate that's really flown the flag. So I put it to clinicians as well, that even if you I appreciate there's, the points that Ross has also raised around conflicts of interest. That can also certainly be an issue too, but time, I can appreciate that as well. But any extra effort that is put in from a clinician's point of view, especially for those early stage startups, it makes a huge difference, because that one contract can literally save an organization when, even though you might not know that from a clinician's perspective, from the company's point of view, having that one company, you'll probably be on their pitch deck for the next kind of 12 months. It's like, here's an example of the clinics that we work with when it's just the one. So, it's just getting that one right. That's, to the point around Nathan's as well, the conflicts of interest in clinicians and startups. So yeah, it's a complex.
I mean, I'd probably challenge that or I'd interrogate that in terms of a conflict of interest. I think generally you're talking, I suppose, about financial conflicts of interest, and so if you genuinely believe that what you do is good for everyone, in terms of good for the patients, good for the organization, good for the company, and you're an advisor in that and you're connecting the dots, is there a financial conflict of interest anywhere? Like, I don't, it'd be interesting to know where you feel the conflict is. I know plenty of, I know NHS consultants that are co-founders of startups that are being used in their hospitals. They're on payroll of the hospital, but they don't benefit from the hospital saving money because it's a public system. I think perhaps then, in me reflecting on that, it's probably because of a private system that the conflicts start to crop up. Even then, it'd be interesting, I suppose, to have that conversation.
I think it's all about expectations and alignment to, and being upfront in these types of situations, and they can be complicated, that's for sure.
It can feel a bit awkward as well. Like, I think if you've got equity in a company, it can feel not right, because I think in healthcare, it's more of a socialist vibe, isn't it? And I think capitalism is not looked upon too favorably in the healthcare world, and making money out of poor health.
Don't make money.
And rightly so in a way. Like, I mean, why should anyone
Right.
It's a discussion and an argument, but it can feel uncomfortable, and I get that. I can, even when I was a clinician, you'd get offers and you just sort of stay away from it because it didn't feel right. I think, again, it was early days back then. I'd certainly changed my position now, because I would just do the things I genuinely believed in, rather than just chasing equity or chasing, cash. It would be like, I can add value here and I should be rewarded for that. And I think as clinicians, if you're worried about conflicts, I think the ultimate defensibility is that you believe in what you're doing for them, for the organization, for yourself, that kind of thing.
Good one. Look, we might share the screen and spin the wheel one more time. We've got 15 minutes left in the live stream. If you've just jumped on and checked it out live, it's Peter Birch from Talking HealthTech podcast, James Somauroo from the HealthTech podcast. I like how you're the HealthTech podcast.
Mate, got in early there. Got in early. Just claim the ground.
And good work, by the way, on the rebranding. Like, remove the hyphen. That makes a big difference in the
So that's the, you know, again, like what I say to people is like, yeah, I was in HealthTech before it was cool. I was in HealthTech before it was a word.
Very cool. Very cool. All right, we'll choose another topic to talk about. You know, there's change in UX that are on there that was suggested. It's either blockchain. I don't know.
Why don't you pick one, Pete? Why don't you just pick what you want to talk about?
Yeah. Well,
I can see where this is going.
Yeah. I just, there we go, locked out. Well, you know, I mean, that's just because it's front of mind, because I've been stuck in this room. I'm in Southwest Sydney, so you know, everyone blames us for what's happening. No. I think we've got a challenging situation now in Southwest Sydney. I find it interesting, the approach to communication here in Sydney. So James, like, you know, like you're probably going to run out of this and go down to the pub or something like that, like in the UK. But we were like that a few weeks ago in Australia, and you know, Delta strain, probably from the UK. No, but I think that it's just generally created a sense of, given the lower rates of vaccine here in Australia, for a number of reasons, our vaccine rates are quite low. Only now just starting to ramp, but not like it's all communication. But you know, in Sydney particularly, it's been interesting seeing how there was an outbreak in, say, the east, or like closer to the city, very different demographic to where the outbreak kind of came from now, which is Southwest, which is more, you know, English as a second language is, I think, 50-60% of the population here. I live in Southwest Sydney as well, so that's my turf. I grew up here, and you know, using Twitter and press releases is just not how communication is done, you know, here in Southwest Sydney, which is how it was very much received in Bondi. So I think the lesson, and so what's happened is that there's, you know, not a great deal of adherence to, you know, your standard kind of masking up, social distancing, staying at home and everything. And then the managing of that from authority or whoever it might be has just not been received well. I think you know, what I've learned through this process is communication, expectation, speaking to the right audience, you know, because I think that if there was some closer work done with community leaders and those that are respected within, you know, the space, there's probably some greater alignment there. It wouldn't have solved everything, but, and of course, hindsight's lovely. It's great. It's easy for me to sit here and talk about that, but it's an interesting reflection. But whereas in the UK, you know, your vaccine rates are quite high, and you know,
we've huge amount of people have had their first dose of 2, but we're opened up and everything's opened up. But I was, you know, saying to you before, like I've never known personally more people with COVID in my group than right now, and so the rates are going up. People are going to weddings and coming back with it. People are going to, you know, loads of parties and coming back. The nightclubs are open, which is just, you know, like, yeah, lot. And speaking of tech, like the COVID app that we've got, everyone's getting pinged so much because so many people have got this stuff now and walking past each other now in like out in the real world, that the COVID app is pinging everyone, telling everyone to go and self-isolate. So loads of businesses are now just closing down for a different reason, which is like nobody can turn up to work because like all the staff have been pinged and everyone's self-isolating. So interesting times.
I saw some videos like in Southwest Sydney. If you need to work somewhere, I think I'll probably butcher this, but you need to get a COVID, like everyone needs to get a COVID test every 3 days. To be able to, if you're going to work physically in a location not from home, you've got to have a test done every 3 days, and they're all drive-through. And so you picture, you know, there's a large number of people that are, you know, driving through, and they're not all drive-through, but they're like, that's where a lot of people are trying to do it, and it's just not sustainable. So it's a logistical challenge. Hey, let's cover, we've got 10 minutes left. People wanted to talk about UX and change, and I think UX came in first. And I've seen a lot of people are on there still. I guess user experience, we've talked about that a fair bit on Talking HealthTech podcast, and I guess we've tied that in with other kind of similar themes around co-design and working with those that are going to be using the solution to make sure it's something that's you know, usable. When I think of UX and healthcare technology, I think of this kind of, you know, there's this emerging kind of group of technologies that are kind of built like consumer apps and are very easy to use when you pick them up. But, you know, still the norm within, especially in a hospital space, but even in general practice here in Australia, the solutions are quite, you know, they feel clunky to use. There's a million clicks that you need to go through and nothing connects and blah, blah, blah. So, you know, there's a while before, you know, those types of like apps that you can pick up and use straight away, you know, start making their way into the mainstream. But it's becoming more and more of a an expectation from clinicians coming through that, you know, these solutions, like they use nice apps at home and in every other part of their life. Why can't they use a nice app or solution in a hospital? So yeah, that's an ongoing discussion. If anyone does have anything they want to raise about user experience, then put it in the chat there. But is there, and on the other point, while we do that too, James, you know, in terms of change management from your side, is there anything that you're doing, working with Somex and some of your clients? I am like, change is always like a constant kind of theme I find in health technology. Is that a common theme for you?
Yeah, well, absolutely, because I think on a lot of the things that our clients are trying to do is, well, stimulate change, right? They're looking for, they're trying to generate buy-in from lots of different people in order to make that change. And, you know, we've even got some clients potentially coming in like from the US that are now looking to come into the UK, and they have to change things and they have to change the way that they're changing things almost, because they're going down. Well, in the US, it's completely reasonable to target clinicians for everything and make sure that they are the ones that love what you do and they are the ones that adopt things. In the UK, not so much. It's going to be management, it's going to be procurement, there's going to be a financial element, perhaps more so, or in a different way. And so, yeah, we have to analyze the way that all of our health tech startup clients are changing things, and we have to figure out what's the way that we get them from A to B quickest through decent communication, through communicating their value propositions properly, through figuring out who the exact audience is and what do we want to leave them with, what's the impression that we want to give them. So yeah, it's a constant theme, and yeah, one that we have to stay on top of all the time.
Yeah, it's the it's probably like whenever I speak to people who are coming into the space and you know, it used to be the conversation as well, like that was always the hardest part about technology, is the adoption side of things. To Ross's point, I think that, you know, that doctors aren't in charge anymore. Procurement and IT hold the keys at a hospital level. He's just added there as well. And yeah, that's Precisely. Right. You know, I think that's certainly the case. I think, you know, interestingly, it's not, I think it's unfair often to say it's the clinicians who, it can be very, like, it's a broad brush statement to say it's clinicians not wanting to use technology. That's why, and they just need to learn how to change more. If that's your constant kind of position, then your app is probably crap. Or no, maybe not. Like it's a complex thing, and I think that that from my side, I think back to the point we were talking about earlier, which is, you know, sometimes it's about, you know, to get started anyway, it's about designing for that, like your champion clinician, and yeah, that might be quite bespoke for them, but you got to start somewhere and then scale it up from there. And that's I guess that's some immediate actionable advice. Look, we've got 5 minutes left, guys. On the wheel, we've covered most things. We mentioned, you know, we can tie together, I guess, decentralization and blockchain into one, because I you know, it is an interesting one. And I remember you, I probably do listen to your podcast more than I think now, actually. You had a conversation about it recently too, and it's come up a few times around decentralization of data. And is it still a hot topic for you?
Yeah, it is. It seems, well, the decentralized web, certainly, with Genero Digital that we're working with, building a platform called Transform on top of Solid, which is Tim Berners-Lee's Internet 2.0, where everyone can have control of their own data. Everyone's going to have these personalized data stores, these pods where all your data is kept. You then have the option to transact with that data however you like. You can trade it to any company you like for whatever you like. You set up the deals, you're in control. And for the companies themselves, they don't have to build a company to get the data they want. They can literally just ask you for whatever data they want and pay you for it or trade you for it. So it's not the case that, Fitbit builds a company just to collect your heart rate data. Fitbit could just literally ask you, can we also have your meal plan, please? And we'll give you this for it, because you own all of that data from all your different platforms, right? So it becomes really interesting. And when you talk about using that in a unified health record and all that stuff, these are conversations going on in the NHS right now. So yeah, it really is like going to unlock something, and the stuff that I'm party to is pretty exciting, man. Like the change that could be made, it's real stepwise stuff. I mean, so much of it is incremental change that we deal with in health tech, digital health. I feel like this is a real stepwise bit that's going to be like, there's the days before this and there was the days after this. It could really make that amount of impact.
Yeah. I made a post a while ago on LinkedIn about, and it was partly tongue in cheek about, it was something like, I just want to have the opportunity to sell my data before I get hacked and someone takes it from me. Like I may as well, make the most of the opportunity. But it's legit, it's currency that's valuable to organizations, not for nefarious reasons, not for reasons of trying to do anything bad or anything. It's more just about improving the quality of their solutions, finding insights that benefit a broader group. And with AI and ML and everything, data is important, and it's not just about how much data, but the diversity of it. So I could see opportunities to target specific people of types of demographic and say, hey, can we have access to this particular information? And, I know, like, it reminds me of, and it's not the same, but it reminds me of a similar theme that, Michelle Perugini from Presigen and the work they're doing here in Australia on some of the collection of data for artificial intelligence, not by like pulling all the data from somewhere and putting it in one location. So this is, again, not blockchain, not anything. It's just, use, rather than pulling information into one spot and then doing AI on it, it's then, grabbing it from different spots. And that concept isn't totally new or anything like that. And a lot of technologies do that already, but it brings a fair point that, pulling together a lot of this data and putting it in one spot, that's just a disaster waiting to happen, obviously. So having it owned by individuals and then controlled, I think there's a lot of interest in that. And I think, but however, like you say, it's not something that's going to happen straight away. And when it does, it's kind of step change stuff. And I think that it's almost like a generational thing. I don't see my mum or grandparents, wanting to, control their own data necessarily. I think that's a bit of a mind blow thing. But, again, generations coming through and different, understanding of it, as Jody said, federating the data here. So I think that, it's constantly talked about, and it's happening in other industries too. So it's only one of those matter of time things, I think. Yeah. We've hit the hour, James. So awesome. We might wrap it up there. For anyone that wants to check out your stuff, James, what should they do? Oh, you should talk about the pigeon as well. Your pigeon's going off, by the way.
A pigeon's going off. The amount of subscribers that. So I have a newsletter, super short newsletter. The 1 minute health tech roundup is kind of its tagline. It goes out on Sunday evenings. It's literally 5 news stories, a couple of podcasts, and a couple of job opportunities each week. It's just basically what I've come across during the week. I've got this couple of guys, Baz and Sharon, shout out to them, who edit it for me and come up with ideas for it as well. But yeah, if you go to www.healthtechpigeon.com, you do need the www weirdly for it to work, but yeah, put that in, you'll be able to subscribe. Obviously the Health Tech podcast, you can Google that. Somex, so somx.co.uk, that's the agency. And if you go to jamesomauroo.com, you can get all of it.
Excellent. Well, look, if you're not across Talking Health Tech, then it's just talkinghealthtech.com. I've, like you said before, James, we'll probably repurpose this audio probably on a bonus episode for THT Plus members on the premium feed. So they'll be looking out for that. I feel like we should do this more often. Just jump on and have a bit of a chat. It looks like it's been well received on LinkedIn mostly. So look, thanks everyone for coming live. And if you're watching it in the video, still leave a comment and tag us in, and maybe suggest some things for the wheel for next chat. But until then, James, stay safe, and yeah, we'll chat soon.
You too, buddy. Have a good one.
Catch you later.